So the last topic of neuro-ophthalmology, that is optic atrophy, color blindness and miscellaneous things. So beginning with the optic atrophy. What is optic atrophy? We have studied in the pathology part. It is an adaptive mechanism, the atrophy. So what does atrophy mean? Simple. In ophthalmology, this atrophy refers to as the wasting away or deteriorate of the optic nerve. Okay, of the optic nerve. Very simple. Now, what are the signs you are going to see in the optic atrophy? These are, you are going to see the optic disc as a pale in color. So, pallor of the optic disc. Okay, then comes a index. What index? This is nothing but Kirstenbohm's index. So in this we calculate the ratio of the small blood vessels and the large blood vessels. Okay. In this the small blood ratio increases and the large blood vessels decreases. Okay. This is an abnormality over here in the atrophy. What is the normal ratio? It is 10. And in optic atrophy it gets less than 7. Okay, this ratio becomes less than 7. The optic atrophy doesn't correlates to visual loss. Okay, so there is no visual loss in the optic atrophy because it is partially damaged or partially wasted. That is why. Now the most important thing in optic atrophy is its type. So what are the types of optic atrophy? These are primary, secondary, not tertiary dears. Here comes the consecutive optic atrophy. Let us discuss them in a great detail. So primary optic atrophy. The definition, what are you going to see in primary optic atrophy? So optic atrophy without any antecedent optic disc swelling. Okay, so there is no optic disc swelling over here, and here you can see after of optic disc swelling. So atrophy is after the optic disc swelling. The atrophy is without the optic disc swelling over here. In secondary there is swelling, in primary there is no swelling. Okay. Now coming up to the consecutive part. Here the optic atrophy is due to any disease and disease in the inner retina. Okay, so at the beginning only of this pathway in the retina part there is a disease. Okay, or there could be any blood vessel abnormality. So there could be an obstruction in the blood vessel. Okay, any erythematous material or plaque or something or the other could obstruct the blood vessel, and this comes under the consecutive optic atrophy. Okay, very simple. Now what is the color of the optic disc in these respective atrophies? In the primary optic atrophy you are going to see a chalky white color. Let us see an image. So clearly here you can see the chalky white color over here. Okay, this is nothing but the primary optic atrophy. Okay, coming up to consecutive optic atrophy, it is waxy and pale and as similar as to the chalky white appearance. So let's see an image. So this image you can see it is chalky and whitish in color. Okay, this is nothing but consecutive optic atrophy. The next is secondary optic atrophy. It is dirty gray and whitish in color, and it has ill-defined margin. Remember students, it has ill-defined margin. Let's see an image. You can clearly see it has a ill-defined margin. You can't distinguish the margins over here, and it is dirty and pale and grayish in color. Okay, very simple. So the next thing comes is the causes of the primary, secondary and consecutive optic atrophy. What are the primary causes or the primary optic atrophy causes? These are optic neuritis, very important. The next comes is tumor, trauma, hereditary, most common, and some toxic diseases also. These are the causes of primary optic atrophy. The secondary optic atrophy causes are papilledema, very important, papillitis, and AION. Now comes the consecutive optic atrophy. The causes are all like obstructions, so CRAO and CRVO, retinitis pigmentosa, important one. So there could be several other causes also for the consecutive optic atrophy. We are just giving a name of someone. So beginning up with the anatomy of the optic nerve, then we'll go to the causes which we studied. Okay, then we'll go to the causes. So anatomy of the optic nerve, very simple, as we discussed in earlier videos also. Optic nerve is the second cranial nerve, okay, we all know, and it is a collection of axons of ganglionic cells, okay, and these optic nerves or these axons cannot regenerate, okay, these cannot regenerate after a damage. What is the total length of the optic nerve? It is 47 to 50 mm. This is the length of the optic nerve. Now moving on to the diseases or the causes, these are optic neuritis. The first comes. Itis, it denotes inflammation, very easy. So there would be a inflammation of the optic nerve. Now comes the types of optic neuritis. These includes papillitis, retinobulbar neuritis, and neuroretinitis. These are the three types of optic neuritis. The first is papillitis, papillitis. Okay, so itself is tell us that it is an inflammation. Okay, and only the optic disc is involved in this. This is commonly seen in the children's. This is commonly seen in the children's. Moving on to retinoblast. So in retrobulbar neuritis, there is an inflammation of the optic nerve, but here the inflammation would be except the optic disc. Okay, so optic disc would not be involved over here, only the optic nerve would be involved. This is seen in adults most commonly. Here neither the patient nor the doctor can see. Okay, so that means basically the patient is unable to see due to this inflammation, and exactly it is at the posterior aspect, so the doctor is also unable to diagnose or see this thing. So here optic nerve is involved, not the optic disc. Then comes the neuroretinitis. In neuroretinitis, the optic disc is involved. Okay, means the optic nerve is also involved. Then comes, it also involves the macula. Okay, so inflammation in both optic disc and the macula is seen in neuroretinitis. Now what is the cause or what you are going to see in neuroretinitis? You are going to see macular star appearance. Macular star appearance. What is macular star appearance? Let's see an image. So this is a macular star appearance that you are going to see, and this is nothing but this is due to the deposition of exudate around the macula. Okay, so in this macula there is a deposition of a exudate. This is nothing but this leads to macular star appearance. You can see such a star. Now the thing you have to remember in this optic neuritis, that is the earliest sign is the Marcus gun pupil. Okay, so the earliest sign to be seen is Marcus gun pupil. There is a central scotomy, you will see a color blindness will occur. unilateral loss of vision is seen. Unilateral loss of vision is seen. There is going to be a pain, and this pain is a retrobulbar pain, okay, because it is due to the movement of the eyeball. So as the patient will move the eyeball, he is going to have a pain. Now what is the treatment of this? Very simple, that optic neuritis treatment trial is going to be in the first stage, okay. So firstly you will be giving a IV methyl prednisolone 1 gram per day, okay, 1 gram daily for 3 days. You have to give it for 3 days, 1 gram daily IV methyl prednisolone, okay. And you have to also give a oral prednisolone 1 milligram per kg per day, okay, and this is for 11 days, students, okay, 11 days. Now this treatment is has turn recovery but does not affect visual outcomes, okay. So it is only a symptomatic treatment, it is not a permanent treatment, okay. So only oral steroids increase the risk of recurrency, okay. So if you are using oral steroids only, okay, not using the prednisolone, then there are risk of recurrency, okay. The next comes is CAMS test, okay, CAMS trial, important one. So this is an effective test. Here states beta infectors IA reduced to the increase multiple sclerosis after the optic neuritis. So basically in this test there is a risk for multiple sclerosis after this optic neuritis. So the next comes is glutaminyl acetate. Glutaminyl acetate. In this you are going to give 20 milligrams subcutaneously, okay. What are the hereditary optic neuritis? What is hereditary optic neuritis? There are 3 to 4 conditions you can see over here. That is Gaucher, which is an autosomal dominant, Behr, Wolfram, and Leber. So Behr is an autosomal recessive condition and it is associated with mental retardedness, ataxia, and nystagmus. Wolfram, it is also an autosomal recessive condition and it is also known as DIDMOAD, okay. And because it is associated with, the important thing over here, it is associated with diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. So the next comes is Leber, also known as LHON, okay. The full form of LHON is Leber hereditary optic neuritis, and this is associated with mitochondrial inheritance, okay, very important, mitochondrial inheritance. Now basically we are going to study this in a great detail, okay. So LHON, also called as Leber hereditary optic neuropathy. What is this? This is a type of point mutation, okay. We are studying the hereditary one, so everyone is a mutation over here. So this is a point mutation. Add the codon, which codon? So 11778, this codon is getting a point mutation, okay. And maternally transmitted, this is a maternally transmitted condition, obviously it is hereditary. Now the most common manifestation is in males, okay, important point over here. Now what are the clinical features over here? So these are the clinical features of LHON. Now in LHON The clinical features you can see is bilateral painless loss of vision. Okay, so here is bilateral painless loss of vision. Another comes the pseudopapillitis, important. Then comes the peripapillar telangiectasis, primary optic atrophy, papillomacular nerve fiber bundle dropout. Okay, so you can see papillomacular nerve fiber, these bundles are dropping out. Now another disease comes over here is toxic optic neuropathy. The name itself tells us there is a toxin which is creating this neuropathy, okay, leading to the neuropathy. It is also called as nutritional optic neuropathy, obviously due to deficiency of any nutritional substance. Okay, so there could be a deficiency of vitamin B, B2, B1, B12, folic acid deficiency. Okay, or there could be a tobacco alcoholic amblyopia. Okay, due to tobacco and alcoholic use, these are also the toxic substances. So what are basically the causes? First is the deficiency of these vitamins. Then comes methanol poisoning. So in the pharmacology part you have studied this point. Okay, now what else drugs can cause this? These are digoxin, isoniazid, chloroquine, the important one for now, and ethambutol. Okay, now what are the visual field effect associated with this toxic optic neuropathy? So these are centro centrocecal scotomy. You can see a centrocecal scotomy, most preferable answer than central scotomy. What is the treatment? Very important part. The treatment for toxic optic neuropathy is 1000 units of hydroxycobalamin weekly for 10 weeks. Okay, so every week you have to give 1000 units of hydroxycobalamin to 10 weeks. Okay, till you have to give to 10 weeks. Now the most important topic over here, another comes is color blindness. Very important topic, students. So basically in color blindness we used to talk about the primary colors only, because majority of the patient comes with the defect of primary color and the defect is only in the primary colors only. What are these primary colors? These are three, known as red, green and blue. Okay, so there is a problem in red, green and blue, and you have to remember these colors in this sequence only. Now the red is called as prota, the green is called as deutera, and the blue is called as tritra. So you can remember as primary, secondary and tertiary in this series. Okay, prota, deutera and tritra. Red, green and blue, these three colors. Now color blindness could be of two types, that is acquired color blindness and congenital color blindness. Let's have a discussion between these two in a form of difference. So the acquired color blindness, all optic nerve diseases, there are red and green color blindness. Important, remember which color blindness is seen in acquired one, red and green. Okay, except in glaucoma patients. Okay, so in glaucoma patients it is not seen. Now macular diseases in acquired, there is a defect in or blindness in blue and yellow color. Okay, except in Stargardt's disease. Okay, very important point over here. Now in old ages and nuclear cataracts, you can see a blue color blindness. Okay, remember the color, students. Okay, blue color. Here it was green and red, not in glaucoma. Blue yellow, but not in Stargardt's disease, and here it is blue. So that was all about acquired. Okay, now the important is our congenital. Okay, congenital further have two subtypes, and these are respectively known as dyschromatopsia and achromatopsia. Okay, dyschromatopsia and achromatopsia. Let us see what are the congenital blindness, color blindness. So the congenital color blindness is the most common mode of inheritance, and that is X-linked recessive. Very important, it is X-linked recessive disease. It is commonly seen in males, and the genes affected over here are chromosome XP28 and chromosome number 7. Due to these deficiencies, you can see a blindness of red and green color, and due to this mutation, you can see a blue color deficiency. Now discussing about dyschromatopsia and acromatopsia. So in a form of differentiation, dyschromatopsia and achromatopsia. So these are basically congenital blindnesses. Okay, and these have further subclassified as dyschromatopsia has trichromatic anomaly, or it could be dichromatic. So the name itself tells us three colors, or di tells us two colors. Achromatopsia, it has further two subcategories. These are cone monochromato and rod monochromat. So basically, what is trichromatic? So all three colors are seen, but the patient will complain that one of these three color is having a defect. One of these three colors. He can identify all these three colors, but there is a defect in between of these three colors. Okay. Dichromatic, name itself suggests di means two, so two colors would be seen and one would be having a anopia. Okay, then comes the achromatopia. Okay, achromatopsia. In achromatopsia, cone monochromat, there is only one colored seen and rest are not seen. Now rod mono rod monochromate, these are, there are no colors seen. Okay, so the patient would be complaining of a pure color blindness, in which there would be complete blindness, and this is nothing but autosomal or recessive disorder. Okay, now the very important part over here, what are the tests for the color blindness? What are the tests? So basically this test, a very common test that you have done in your vivas or in your practical classes, that are Ishihara chart test. Okay, in Ishihara chart test, what category of test it is? It is pseudo isochromatic chart. It is a pseudo isochromatic chart type. The another which we'll talk about, Hardy Randley Rilder, this is also a pseudo isochromatic chart. Okay, so Ishihara chart, it is the most common one. Okay, and you can see numbers in Ishihara chart. Remember this, on Ishihara chart there are numbers, not alphabets. Numbers are written over here. Okay, but in Hardy Rand you can see circles and crosses and alphabets over here. And this is the screening for infants. Remember, this is the screen for infants. The next, the modern technique used nowadays is Franworth Munsell 100U. Franworth Munsell 100U. This is the most sensitive test used nowadays, and it has 85 test caps. Okay, like this, as you can see. There is another one, Franworth Mitchell 15 use, and it has 15 test caps. Okay, placed like this. Now another microscopical examination, that is Nagel's anomaloscope, and it is used for diagnosis of severity. Okay, it appears like this. Okay, another some other tests are also there, but the most commonly used is this. The next we are going to talk about papilledema. Papilledema is defined as the swelling of the optic nerve, and it is due to increase in the intracranial pressure. Very important. So there is a swelling of the optic nerve, as we can see by the name itself. Okay, papillae, optic disc, and there is a edema also. So why is this edema occurring? This is due to the increased intracranial pressure. So what are the clinical features of papilledema? It would be always bilateral except in the foster Kennedy syndrome. Okay, it is painless, very important, because no inflammation is over here. That is why it is painless. What is the pathogenesis of papilledema? What is the pathogenesis of papilledema? So there is an increased intracranial pressure. There is a increased intracranial pressure, and this would be transmitted along the subarachnoid space, due to which the optic nerve would be feeling up pressure under. Okay, so the optic nerve would be under the pressure, and this would block the exoplasmic transport, which will lead to the stasis, and when stasis occurs, then there is edema, and edema would be seen, and you can see congestion also, which will further lead to edema. Now what are the symptoms of papilledema? The earliest symptom of papilledema is headache. Okay, so the headache is worse in the morning. There would be a severe headache in the morning. The projectile vomiting is seen. Okay, headache, projectile vomiting. Again, vision is normal, but gradual or painless loss of vision occurs for a few seconds. Okay, so only for a few seconds the patient will complain that for few seconds my vision is lost. Okay, and it is painless. Now the next comes is, according to Fresson scale, we have graded the papilledema. Okay, so in the first grade you can see the C-shaped, okay, C-shaped margins, or you can see a C-shaped halo formation. C-shaped halo formation, remember the word halo. Okay, so you can see a C-shaped halo formation. Then in grade 2 the halo becomes circumferential. And in the grade 3, the major blood vessel, as you can see in this image, the major blood vessels are going to be narrowed. Okay, they are going to be narrowed. In grade 4, clearly you can see the major blood vessels are lost completely. As you can see, distinguish between these two images. Here are some blood vessels, but major blood vessels are lost. And in this image you can see there is a loss of major blood vessels. Okay. In grade 4, in grade 4 there is all vessels. In the grade 5, in the grade 5 all vessels are gone. Okay. You can have a distinguish between the 4 and the 5. You can see some blood vessels over here. Yes. And all blood vessels in the fifth are gone. All are obstructed. The next comes is AION, that is nothing but anterior ischemic optic neuropathy. I hope the word is clear to you. Now it is of two types, arthritic and non-arthritic. Okay, very simple. Let us discuss the arthritic one and the non-arthritic one. So it occurs due to giant cell arteritis. The arthritic one occurs due to giant cell arteritic, and this non-arthritic occurs due to short posterior or ciliary artery. Okay, there is a occlusion in the short posterior or the ciliary artery that causes the non-arthritic AION. Okay. Laterally, what manifestations you can see? A bilateral loss of vision is seen over here, and a unilateral loss of vision is in the non-arthritic part. The severity in the arthritic, it is much severe than the non-arthritic one. It is moderately severe. The vision is approximately less than 6 or 60, and it is more than 6 by 60. Pre-monitoring symptoms like pain, okay, flaget, these are present over here and these are absent over here. Very important. Okay, so these points are very important. Now the association. But first the optic disc appearance. So how the optic disc appears in arthritic one? It appears pale in color. Pale. In non-arthritic one, it is hyperemic. It is hyperemic due to exudate coming out, okay, or the rupture. Now it is associated with tender tympanic artery, headache, and cranial nerve paralysis. And this is due to diabetes, hypertension, hyperlipidemia. The most important part is the treatment. There is no treatment for non-arthritic AION, but there is a treatment for arthritic AION, and that is cortisol therapy, and aspirin is also used, but the important one is cortisols are used. Now coming up to the congenital anomalies, the first comes is the morning glory syndrome, and the important thing over here is the blood vessels are emerging in radially. In radially, you can see these blood vessels are emerging in. Okay, and large optic disc with excavation. You can see these things. The next and the last comes is myelinated nerve fibers and the retinal ganglionic cells. These retains the myelin sheath, very important, and due to which the visible as white streaks. So due to this there is a white streak formation, as you can see in the diagram. This white streak formation is due to retinal myelin sheath in the retinal ganglionic cells. Now in the upcoming video we are going to discuss the very important topic, that is squint. Very important topic, students.